All right, so I'll be talking about CGRP. So basically, what is CGRP, and you know what that means for migraine. Disclosures: I really don't have any. So this is just basic outline of what I'll be going over. CGRP, its role in migraine, how some medications act on CGRP, and hopefully some common questions that I took the liberty of answering ahead. And of course, if you have any further questions, I'll be more than happy to answer. So CGRP, it basically stands for calcitonin gene-related peptide. So what is a neuropeptide? A neuropeptide is just a signaling molecule in the brain. It's basically like a messenger boy, going from one part of the nerve to the other part of the nerve, signaling pain. So CGRP specifically, it does a few other things. It regulates blood flow by relaxing the blood vessels. It also mediates sensory perception in pain, which is probably the most important part here. And additionally, it modulates immune system, which is somewhat still of a mystery. So just a quick history recap of CGRP in migraine. It was actually first discovered in 1983. And then as you can see along the years, it's been a hot topic and a hot target for treatment of migraine and migraine attacks. Their study in 1990 showed that CGRP was elevated in blood during a migraine attack. So that became a pretty important study where it shifted our paradigm on how to go about treating migraine. Then in 2008, Telsagipan showed some promise as an acute treatment. And since then, we've come a pretty long way to 2020 when GPANs, the first medications approved as CGRP antagonists for acute treatment. And then 2 years prior to that, of course, the CGRP monoclonal antibodies for preventive treatment. And I'll go over that in a little bit as well. So CGRP in migraine, it actually is increased during an acute migraine attack, like I discussed earlier. Triptans, as we found after the discovery of CGRP, that they reduce the levels of CGRP during an acute migraine. And then that decrease directly corresponds with migraine relief. And then CGRPs also increase between migraines in persons with chronic migraines. So someone who has more than 15 headache days per month, more often, even more than that, they've been shown to have elevated levels of CGRP as compared to someone who has no migraine or even episodic migraine. And then the degree of elevation of CGRP predicts a positive response to Botox. So when patients get Botox and then right before their next round, we measure their CGRP. If the levels are elevated, we can see a more robust response. So how do these medications really work? So these are your nerve endings. As you can see, up top is your trigeminal nerve with receptors. Receptors are basically where these proteins end up and then send a downstream signal. At the bottom is what we call post-junction cell, where more receptors are present and CGRP is being taken up. And then to the left is the meningeal artery. These are blood vessels. So CGRP affects all three of these endpoints. And then this is how the medications or at specific sites where the medications work. So your triptans work at the serotonin receptor. Your dietans, which are basically the newer version of triptans, work on a completely different receptor. So if you notice, they don't work on the meningeal artery, hence they don't cause the vasoconstriction that's the most worrisome. And then, well, there it is. And then GPANs. So GPANs work at the receptor for the CGRP. So they prevent the CGRP from binding to the receptor. And anti-CGRP monoclonal antibodies, they work on two different sites. So Aimovig or Arenumab binds to the CGRP itself, the molecule. Oh, sorry. It binds to the receptor as well. And the other two, Ajovy and Emgality, bind to the molecule itself and don't let it get to the receptor. And last but not least, toxin or more commonly Botox, prevents the release of the CGRP. So there are little vesicles that are tightly packed with CGRP, and Botox prevents that release. So that's how it works over time. CGRP monoclonal antibodies. So now there are four of them, with Vyepti being recently approved as well. The first three, some, if not all of you, may be familiar with: Erenumab, Galcanezumab, and Fremanezumab. Like I was saying, Erenumab binds at the receptor site, so the CGRP can't get there, and the other two are ligand, so they bind to the CGRP itself, so they can't fit into the receptor. The way I describe it to my patients is the metaphor of lock and key. So key being the CGRP, and lock being the receptor. So Erenumab binds to the lock and doesn't let the key fit in, and then the other two bind to the key itself and don't allow the key to get into the lock. They have different dosings. They all have a little bit of their nuances, but overall, they all have similar efficacy. Aimovig or Ranumab comes in two different doses. Galcanezumab comes in once a month dose, but the original dose, the initial dose, is a loading dose, so you get two injections the first time. Ajovy comes in two different doses, where if you're doing well on once a month dose, you can be transitioned to once every 3 months dose, which is similar to Botox. And last but not least, Vyepti, which is actually an infusion. So if you're uh, resistant to injecting yourself, like myself and most people would be, you can just go and get a monthly infusion or a quarterly infusion if that monthly infusion is working well for you. As far as side effects are concerned, constipation seems to be the more common side effect with Erenumab, as opposed, in addition to injection site reaction. Same goes for the other two, injection site reaction being the most common one, but there are some hypersensitivity reactions as well, and occasionally nausea. Now to the GPANs, the newest class of medications that we have to offer. So Ubrojapan or Rimejapan, you may have seen commercials for them with Serena Williams or Khloe Kardashian. So Ubrojapan and Rimejapan work in a similar manner. They block the CGRP from getting to the receptor. These are acute medications and they're oral medications. So similar to your triptan medications. Ubrojapan actually is used very similar to any triptan medication, where you take it at the onset of the pain and you can repeat another dose 2 hours later. However, Rimejapan is a little bit different, where it's an oral disintegrating tablet, and you only just need one tablet for the 24 hours because it's longer lasting. Nausea seems to be the most common side effect with both of these. And the only thing to additionally worry about or keep in mind is the interactions. So Ubrojapan specifically also interacts with certain other medications. So if you're on verapamil, antibiotics, or barbiturates and or antifungals, just keep in mind that your levels of your medications may be affected. So some common questions that my patients frequently ask: can I get my CGRP levels tested? Well, unfortunately, there's no commercially available test. The half-life is only about 7 minutes, so we would need a specialized lab to draw your blood and test it right away, which would be nearly impossible. So for now, it's just done in research studies. What else does CGRP do in the body? So that's a great question that I get asked quite frequently, and I honestly, we don't know what it does completely, but what we do know, it's involved with bone formation, it's involved with GI motility, it's also involved with hair follicles, and they actually release CGRP. CGRP receptors are found in uterus, the placenta, penis, semen, and prostate. CGRP levels are increased in certain inflammatory states like arthritis and obesity, even during a heart attack. But in chronic heart disease or in diabetes, they are decreased. And again, this is not an exhaustive list. This is just some of the highlights about what we know about CGRP. Uh, Side effects. So, how are side effects determined? Basically, they are usually on the label. So, they're determined during the studies. There are different stages of a study of a clinical trial, and that's how they determine the side effects. And then there are also post-marketing reports where if you think you are having a side effect to a medication, you can either tell your doctor or report it to FDA, and they will look into it. And that's how more and more side effects are added. So, for example, Arenumab came out with a new warning last year that it may cause hypertension or elevated blood pressure as well. So that was reported after seeing it in clinic over and over. Another question, if I've tried one CGRP antibody, should I consider trying another? So if it's a little bit more complicated. So like I said, they work in a similar way. So you may think no, but if you're having lack of benefit to one, it's very possible that you may have benefit from another type. So the answer is actually yes. The medications are slightly different, so you can definitely try another one. But now, if you tell me that you're having side effects on one, and will you, if you try the other one, will you have less side effects? That is a little more iffy because the side effects that you're having are more likely due to the CGRP and how it interacts in your body. So all of these medications are going to interact with that CGRP. So you may not see improvement in your side effects, but it's always worth a shot. And why don't these medications help me? So that is, I think, one of the better questions here, not because it's just a better question, because it applies to many of my patients and probably to many of you. It's because the patients that they use in trials are what we call quote unquote idealized. So, they're your textbook patients where they're having exactly 15 or 16 headache days per month. They can clearly tell you that 6, 7, 8 headaches are severe, the rest are mild, they have classic symptoms. However, in the real world, it's hard to delineate when your headaches are ending, when your headaches are starting. It's not just nausea and light sensitivity, it's confusion, not being able to think or function properly. There are so many other side effects and so many other associated symptoms with the migraine attack that clinical trials just kind of overlook at times. So migraine is, like I states, very complicated. So CGRP is not the one and only target there. So that's why it's possible that these medications may not help you as much as they helped those people in the trials. Can you combine a CGRP monoclonal antibody and a CGRP antagonist like a GPANT? The answer is yes, probably. The reason for the probably is we just don't have enough data quite yet. There have been some small studies done. I cited 2, but there are 3 or 4 now. They're just smaller studies looking at patients anywhere from 2 to 18 patients, seeing how they respond to both of these medications together and whether there are any adverse effects. And thus far, no serious adverse effects have been noted, and they have been shown to be effective together. Again, unclear why or how, which is what we're going to look into, and obviously probably tells us that there's a lot more going on than just CGRP. However, yes, you can combine these 2 medications. And of course, the long-term effects are unknown because these are still relatively new medications. And then how often can I take it? So Ubrelvy, like I mentioned earlier, is 2 doses in 24 hours, just like the Nutriptan. Nurtec is a little longer lasting. It dissolves on or under your tongue. So just 1 dose in 24 hours is enough. If it doesn't work for you, you can take a second dose, which they did in the study, but it wasn't very effective. So chances are you're not going to find relief after a second dose if you didn't after the first dose. And then lastly, unlike triptans, these medications probably can be taken on a daily basis or more frequent basis because they're actually doing studies on atogepant, which is another GPAN, and rimegepant, which is the Nurtec, to see if they can be used as preventive medications. So Nurtec their trial is almost done. I think they're going to publish soon if they haven't already. They use it as every other day, and we'll soon find out how effective that will be. I just had a preliminary look at the data, but I'll wait for the final results. And then last but not least, can I take it if I've already taken my triptan? So the answer is yes. Again, there are no specific studies or randomized control trials that have been done for this. However, in the Ubrelvy study, uh, the study they used to approve Ubrelvy, the patients were allowed to take their triptan in addition to Ubrelvy, and they didn't seem to have any serious or major adverse effects. So yes, you can take it with your triptan. Um, I recommend many of my patients to just stagger it. So start with one and add on the second one if they need to, if their pain isn't getting any better. So with that said, this is Dr. Doherty's cartoon. She credits Joe Sutcliffe, but I think this is where we are in the world of migraine. You have different viewpoints and different areas where we're targeting, and everybody seems to think it's, you know, their viewpoint is the the golden key, but it's probably a little bit of everything. It's a multifactorial disease process, and we need to treat it as such. So I will take questions now.
Sorry, I was on mute still. I love that cartoon. That's great.
Thank
I have not seen that one yet.
you.
Excuse me for interrupting. Dr. Suri, could you turn on your camera? Because we can't see you. We'd love to be able to see you.
Sure, of course. Give me 1 second.
Thank you.
Yeah. Can you?
Now we see you. Nice shirt, by the way.
Thanks.
Okay, go ahead. Go ahead, Katie.
Um, yeah, that cartoon's great. Vyepti is the newest CGRP. How have your patients been responding to the newest CGRP? Can you share with us any of that?
So it is the newest CGRP monoclonal antibody. It is an infusion, and one of the benefits of it is, unlike the other CGRP monoclonal antibodies, where their peak time in the serum is 5 to 7 days, with Vyepti it's about 1 hour. So patients who do respond to it, they respond to it very quickly. So before they even get home, usually their headaches are better. But that's if they respond to it. Unfortunately, because it's an infusion, insurances haven't been uh, playing ball, so to say, until more recently. So we haven't had too many patients take Vyepti, but just speaking with Dr. Doherty and Dr. Elani, they've had a couple of patients that they've been able to get the infusions for, and they've been helpful. So we're hoping to start enrolling or start having more and more patients get Vyepti.
Oh, that's great news. And that's another question. Um, I've heard so many people talk about all these great CGRPs, but not being able to get approved for it. Do you have any advice on patients and what they can do to try to get approved for these medications?
Yeah. So two things I would say. One, as providers, we should be more cognizant of the insurance obstacles and how to work with them. So I go out of my way to try to do peer to peers. If so first of all, first and foremost, I have a Cover My Meds account, which makes prior authorizations very easy. So if you're able to do that as a provider, it takes about 5 minutes, and you can get a prior auth within the hour. If you run into any issues with that, you can always do a peer-to-peer with one of their physicians, the insurance company's physicians, to advocate for your patients. And then secondly, patients themselves. I think they don't realize, but they can actually do a lot by advocating for themselves. So one of my patients who's actually part of the monthly Miles for Migraine Act Now program as well. She is great at advocating for herself. She was able to get herself Botox every 10 weeks instead of 12 weeks because she realized that she was getting worse. So basically, calling the insurance company, speaking with them, telling them your story. And in the end, as cynical as it may sound, for them, it's about saving money. So if you if you tell them that if I don't get my medication on time, I will end up in the ER, which is going to cost you a lot more. Uh, they seem to listen to that. So if that's what it takes, then that's what you have to do. So working together as a team, I think, is the best way to go about doing that.
I love that. That's great advice. Thank you so much.
Yes.
And I'll share that with my support groups too. So I wrote that down when you all that information. Thank you. Is it true that you can't take a CGRP with Botox for migraine at the same time?
I'm sorry, you said can't or can?
That you cannot.
No, that's not true at all. I actually have a few patients of mine who are on both CGRP monoclonal antibodies and Botox. It really just depends on insurance. Most insurances will actually cover it now, except Blue Cross Blue Shield. So if you have any other insurance, feel free to speak to your provider to see if one or the other would be helpful. I actually did a research on it. So we're almost done publishing the paper, but my abstract's out there somewhere. It showed that uh, those two working together actually have a synergistic effect and cause more of a relief than individually alone.
Okay, great. Someone asked, why have insurances stopped paying for Botox? Have you found that recently?
Stop paying for it? Yeah, so we actually ran into that issue. It was at the end of last year, beginning of this year, when certain insurances, and more importantly, it was actually the specialty pharmacies that stopped carrying it because it was costing them more. Really, again, it's all about the bottom line in the end. So luckily, some of these insurance companies were able to reach out to other specialty pharmacies and find second and third alternatives. So, for example, CVS Caremark seemed to be one of them that was having issues supplying the Botox. So, if you again contact your insurance company or whoever takes care of the Botox from your provider, contacts the insurance company, and they will let them know what the secondary or third alternative for the specialty pharmacies are.
Okay, great advice. And do you ever recommend to your patients to detox from their medications and start from the beginning with new medication therapy? So, completely starting from scratch and then,
Yeah, so that is a great question and a very complicated question. Yes and no. I never take them off of everything. That would be, I think, careless. But oftentimes, when we have patients coming in from other providers and they're on 5, 6, 7 different preventive regimen medications, I do often try to limit their medication burden. So I will ask them which one do you think is helping or which one do you remember being the most helpful. So kind of go in reverse order and slowly taper off one at a time. And obviously, if their headaches get worse or become more frequent, then we just restart that medication right away and work our way down. While doing that, what I try to do is find other alternatives too. So in case these medications come off, you have something else there to kind of protect you and prevent you from going back into a bad cycle. So it becomes a balancing act, but yeah, I try to limit the medications rather than detoxing, I would say.
okay, great, thank you. Okay, one more question here. Nurtec is limited in the number of tablets health plans pharmacies will allow. I think we get 7 in a pack because I have Nurtec. When will the number of tablets per prescription change? Well, do you know if that frequency will change? We'll get more or...
That's a good question. Yeah, so unfortunately for acute treatment, it probably won't change. It'll remain 8 tablets. I think you can get up to 8 tablets per month. However, Nurtec or Megapant is at the finishing stages of their study to show that it's effective for preventive medication, and they're just waiting for the FDA approval. So when that comes out, you'll be able to get 15 per month. So uh, chances are your provider may be able to do both. You get preventive and abortive, so you may be able to get up to 23 per month, but we're looking at a few more months until you're at that point.
Great, that's good news. And
Yeah.
actually, here's one more question that just popped on. I'll ask, and this will be the last one. Do these medications work better for those that have multiple chronic pain conditions, including migraine?
Good question. So CGRP specific medications can work for that because, again, we don't know enough about CGRP, but CGRP is involved in uh, pain centralization, pain perception, as well as other disease processes. So it's possible that these medications alone may be able to help with other pain diseases as well. Um, but again, they're still working on doing more specific studies. I've read some review papers where they have been helpful in, for example, rheumatoid arthritis pain, but yeah, no specific randomized controlled trials that I know of yet.
Okay, perfect. Well, thank you so much. I asked you that last question because I know you said you're heading on, I think, to the pain specialty side of things. So I didn't know if you were doing some extra reading on that, but hopefully it will. And we thank you so much for your presentation. We learned a lot, and good luck with your future studies.
Thank you.
And hope to have you back.